So, fancy meeting you here again. Well, let's talk about the antitussives. So, what are the antitussives? They are those drugs that are used to control or suppress coughs. The cough could be caused by respiratory tract irritation from cold or allergies. And why do we get them? Well, the respiratory secretions and foreign objects are normally removed by the cough reflex. That induces coughing and expectoration. This is initiated by irritation of those sensory receptors that are in the respiratory tract. So there are two basic types of cough. There's the productive cough, which is when we have congestion and there's excessive secretions that need to be removed, and the non-productive cough. This is often called a dry cough. So a cough that is less than 3 weeks is usually called acute. If it's 3 to 8 weeks, it's typically referred to as a subacute cough, and then some of our patients have a chronic cough. You may hear this in those patients that have COPD or that smoke. They'll clear their throat and have a low cough that occurs just on a routine basis. Many of the times, the patient doesn't even know that they have a cough because they've become so accustomed to it. Now, most of the time, a cough is beneficial when it's removing those excessive secretions or potentially harmful foreign substances. But in some situations, coughing can actually be harmful, such as after a hernia repair surgery or some other types of surgeries. We don't want them to cough. So our antitussives can be used to stop the cough. And these are the drugs that stop or reduce it. Now, they're opioid and non-opioid. We only use antitussives for non-productive coughs. We will also use them in cases where coughing is harmful. They should always be used with caution because, generally speaking, if the cough is productive, it's doing its job. It should not be suppressed. So it's really important that the underlying disorder has been addressed and what is causing the cough. So we don't want to retrain respiratory secretions because that can actually be more harmful. So if the patient is having a non-productive cough or it's causing muscle pain or interfering with sleep, then that sort of cough should be suppressed. Antitussives come in both liquid and tablet forms. And often the patients will prefer a cough syrup for cough suppression, but there are many over-the-counter cough syrups that patients will take. So what is the mechanism of action? Well, if we have the opioids, they suppress the cough reflex by directly acting on the cough center in the medulla. And they're the most effective in suppressing the cough. So codeine, as the narcotic antitussive, is used to suppress cough by when we have a chemical or mechanical respiratory tract problem. And because it is a narcotic agonist analgesic, they will have mild to moderate pain relief if they have that. The antitussive dose of codeine is actually much lower than required for the doses that are required for analgesia. So the side effects are less frequent with the antitussive dose. It is beneficial in patients who have cough-related pain or complications like costochondritis or sleeplessness caused by this deep or persistent cough. But as a result, because it is a narcotic, you can have nausea, vomiting, sedation, dizziness, and constipation. You can also have allergic reactions to the opiates, and those usually are manifested as pruritus or urticaria. They're prescribed in very small amounts, and patients need to be followed very closely if they're given an antitussive with an opioid. We don't see the hydrocodone used as much anymore because of our problems with opioid crisis that we have. So typically you're going to see the codeine. Sometimes you'll see codeine ordered in Finnegan, and that is a really effective combination, but is also used very sparingly. So our non-narcotic then antitussives suppress the cough reflex, most often by numbing the receptors and preventing the cough reflex from being stimulated. So they lack analgesic properties and they're not as effective as the codeine in suppressing the cough, but they lack the potential for addiction. And so that's what makes them very important in the treatment of the cough. Dextromethorphan, you'll find this in Vicks Formula 44, Robitussin DM. It's pretty common, and it's in many of our over-the-counter cold medications. Sometimes prescription preparations will use it, and it's frequently in a combination with decongestant, antihistamine, and an expectorant. So benzonatate, also called Tessalon pearls, that's the brand name is the Tessalon pearls, is a little capsule that's swallowed whole, and it causes a temporary local anesthesia of the oral mucosa, of the throat. So it lacks the central nervous system effects of codeine or dextromethorphan. But it is often used in our frail and elderly patients. Then also it's used for those patients that need to be able to continue to drive or perform activities that require mental alertness, because we're literally anesthetizing the cough reflex in the throat, so it doesn't have any effect on the central nervous system at all. So when we look at these antitussives, the indications for this medication is to stop the cough reflex when the cough is either non-productive and or harmful to the patient. We will look at the adverse effects with the benzonatate. It's dizziness, headache, sometimes sedation, nausea. Oftentimes we find that that's simply because of the anesthesia qualities of it, if it has a systemic effect at all. And then our dextromethorphan, dizziness, drowsiness, nausea, our opioids, sedation, nausea, vomiting, lightheadedness, and constipation. And of course, with the opioids, you're going to have that potential for addiction if there's addiction as a problem in the patient. I also want to point out, even though these are small doses with the opioids, with our geriatric patients, we want to make sure that we use it with caution. We also want to use it with caution in anyone who has severe liver impairment, kidney function problems, hypothyroidism, Addison disease, urethral strictures, or prostatic hypertrophy. And we would not use codeine in a premature infant. Do not use it in a premature infant. Opioids cross the immature blood-brain barrier, and a preemie has an immature blood-brain barrier. So to the greater extent, for all practical purposes. So you could have significant respiratory depression in codeine in premature infants. If it's given to infants or small children, it is done with very extreme caution, and we monitor the dosage very carefully. So among our nursing implications for these patients, we want to make sure we're performing respiratory and cough assessments, that we're assessing for allergies. A persistent cough can be a sign of a very serious condition. So we always want to instruct the patient to contact their health provider if the cough persists for longer than a week. We will instruct these patients to avoid driving or operating heavy equipment due to possible sedation, drowsiness, or dizziness. If they're taking chewable tablets or lozenges, they should not drink liquids for 30 to 35 minutes afterwards. With the Tessalon pearls, because we have anesthetized the throat, we want to teach the patient not to chug or upturn a drink and like you would chug a drink. You wouldn't want to do that because of the risk for aspiration or to choking. Reporting, again, if there's a cough that lasts longer than a week, if it is accompanied by a persistent headache, if it's accompanied by a fever or a rash. Remember, antitussive drugs are for non-productive coughs. We want to get that stuff out of there. And then we want our patient to be monitored for the intended therapeutic effect. With our Dextromethorphan. We also know that the WHO, the World Health Organization Committee on Drug Dependence, says that dextromethorphan can produce a very slight psychic dependence, but no physical dependence. So we want to be sure that we're monitoring the patient, that they don't psychologically feel like they need to have this cough medication, particularly a cough syrup. Always using them with caution in our sedated or debilitated patients. So we have next on the list, last but not least, we'll talk about expectorants. I'll see you here in just a few minutes. Thanks.